How do you work with this?
Yeah. So you go backwards.
This is forward.
This is forward.
This.
The big one.
Okay. All right. Um, Thank you again for inviting me. I'm Eric Finkelstein from Tel Aviv. I'll do it fast. This is more a philosophical. This is my disclosure. Now, I was asked to talk about this topic. Should we slow down? Now, Ioannis, this is the first time in my life that you're gonna listen to me talking against Taver. And I'm gonna be a spoiler because the answer is definitely yes. We should slow down because we're driving a little bit too fast. Now, in order to say so, I'm going to talk a few words about why are we running, then why should we slow down, and then about my perspective regarding the treatment of aortic stenosis. Now, this is Donald Rumsfeld. I don't know if you know him, but he was the Secretary of Defense in the United States under Gerald Ford and later on under George W. Bush. In between, he was and the CEO of pharmaceutical company and then CEO for Gilead Sciences. And I'm telling you about him because he wrote a book known as The Known and Unknown, a memoir. And since then, he created what we call today the Rumsfeldian thinking. And this says that there is the known knowns, namely those things that we know, that the known unknowns is things that we know that we don't know. And the most dangerous one are the unknown unknowns, these things that we don't know that we don't know. So why are we running? So let's talk about the known knowns. So we know from all the studies that from the partner of the extreme, high, intermediate, and finally the low risk, and in parallel, of course, the core valve, we know that TAVR, as opposed to medical therapy, is superior in the inoperable patients. It's non-inferior or even superior in some aspects in high, intermediate, and low-risk patients. But we tend to forget some known knowns. We tend to forget that all those clinical trials are not for all patients. And they always excluded patients who were very young, who had bad anatomy on transfemoral, had severe coronary artery disease, severe LV dysfunction, CKD, etc., etc. Even though we're doing so far about 2 million cases of TAVR, the budget of this yearly is $6.5 billion in the last year, and 3 times more than that in the next 4 years. It's expanding into very low risk and younger patients. We're having now newer versions, and the surgeons are slowly but surely believing and going into it. So should we slow down? Are we running too fast just because there are no knowns, or are there any other reasons? So I'm not going to talk about all the dirty reasons like our ego, but definitely one of the main reasons we mentioned it today is that, as Michael Mack said, when 2 procedures are equal, the less invasive, and this is what the patient wants. And if the patient wants, we sometimes agree. So how should we slow down? Well, we should slow down mainly because of the known unknowns. And I don't know about you, but I don't really know what's the durability. I don't really know the importance and the magnitude of halt. I don't know whether to use the cerebral protection device or not. I don't know the different aspects of bicuspid, the meaning of post-TAVR bundle branch block, and whether to do it in asymptomatic patients. I have many other knowns, unknowns. Probably the main issue is the durability that I don't know. Even though the notion and all the studies we have, we still have a question. And the question is that it's a huge difference between an 80 years old patient or a 65-year-old, because in one, the rate limiting factor is the durability of the valve, and in the other, the main rate limiting factor is the durability of the patient. So, for example, we were talking about the preparation. If we don't do it, it increases the meaning of halt, it increases the valve failure, and increases the bad outcomes clinically. So lesion preparation, which we know that we should do and we're not doing always, is similar to what have, and I told you it makes me a deja vu of the restenosis in a stent. And in order to optimize, we should predilate and do as much modification as we can in order to expand the life of the valve. We think that we know that TAVR is safe, like Uri Landis wrote once, but it's not as he wrote, and he knows that because it was a little bit before we started to understand the meaning of coronary obstruction, the VTC, the VTA, the neoskirt. We didn't know then. We still don't know how to optimize the penetration to the coronary artery after a TAVR. We don't really know. I mean, we're trying to do the coronary and the commissural alignments, but we don't really have dedication for this. And this is so important because I don't know if you're aware of, but 74% of PCI centers in Europe don't know what TAVR is, don't know what's coronary alignment, what's leaflet, etc., etc. So what's my perspectives? I'll tell you what. Look, I think that we should have a much better pre-procedural imaging in order to predict directly what is going to be the success of the procedure we're doing, and to do individual stimulation in order to predict which valve this patient is better to have, not what we feel, but as a result of this imaging. And we should have it mainly to predict whether in this patient, the next procedure of TAVR will be good for him, and otherwise to choose another option. Now, this is the road we took, and we have started TAVR as an exceptional journey, and you cannot blame me for not having this and very happy with it. But TAVR car is driving now towards a place that it is exclusively almost the only option of treatment. And I'm saying this because in young and otherwise healthy patient, is just safe and doable is still good enough. So you're asking the question whether we're running too fast, Ioanni? Yes, the answer is definitely yes. We are running too fast, and we have to slow down a little bit. And I want to remind you, TAVR gave birth to structural heart intervention. I remember that day. And should we not make the same mistake we have done with our TAVR expedition in future structural and valvular intervention? Thank you so much.
Thank you, Eric. It's always thought-provoking what you say, and we always keep it, deep in our hearts what you say. So we remember that in the difficult situations, and this is food for thought. This is we discussed a lot in the heart team about what we should be doing in younger patients. And maybe we can have a discussion after Dr. Patsali's talk on TAV in younger patients.
That's my family, I'm sorry. You can take it.
It's okay. It's
the best picture of the day.